So I am delighted today to welcome some experts in our field to join us in the webinar. First of all, from Ireland, Dr. Claire Moran, who is the laboratory manager of Repromed in Dublin. She graduated from University College Dublin with a PhD in pharmacology and started her career in embryology in 2006 at the Liverpool Women's Hospital. After that training, she returned to Ireland and she's gained considerable experience in the field of reproductive medicine across some of the leading fertility centres in Ireland. She has a keen interest in research and development in this area of reproductive medicine, and we welcome Claire and thank you for joining us today. Also, I would like to welcome Karen Sage. Karen Sage is a genetic counsellor, and she's also the founding partner of Fertility Genetics, a genetic counselling company. So please feel free to go and have a look at their website. She graduated in degree in biology and genetics, and then did a postgraduate certificate and an MSc in genetic counselling at University College Wales in Cardiff. Cardiff University in Wales. Karen was one of the very first genetic counsellors to specialise in fertility issues, and she's led genetic counselling services in a number of the leading IVF centres in the UK. She specialises in pre-implantation genetic testing counselling, monogenic disease, structural rearrangements and aneuploidy, as well as other forms of genetic counselling for preconception, enhanced carrier screening, and general prenatal and cancer genetics. She has a background in industry and education and has worked with organisations like Health Education England, producing specialist pamphlets for the NHS, as we have prepared over the years to bring genetics into mainstream medicine. So welcome to this, and we look forward to hearing from you later, Karen. Also from Cooper Genomics, two of my colleagues, Lena Zoghi, who is the Global Product Director for our pre-implantation genetic testing products. Lena has been with us for a number of years, having come from GeneDx, and has considerable experience in pre-implantation genetics. And Lena is going to give the presentation which follows this, and then join us for the Q&A later on. Welcome, Lena. And last but not least is Dr. David Grimes, who's been colleague of mine for over 15 years, since we were together in a company called Bluenome. Bluenome back in 2008 was the first commercial PGTai test available, and David helped develop much of the technology. And then when Bluenome was acquired by Illumina, he went on to join Illumina, and since then he's also been with me in Genesis Genetics, which was acquired by Cooper Surgical in 2016. David is the Director of Business Development for Cooper Genomics and has great experience in the field of PGTA and PGT-M and SR, and he will be joining us as well for the Q&A at the end. So welcome all, and without further ado, I'd like to hand over to Lena, where she's going to give us an introduction to this area. Lena.
Thank you so much, Tony. I appreciate it. Hello, everyone. Thank you for joining us today. I'm going to give you a brief overview as an introduction of our topic today and get into our presentation. So we will be talking about a comprehensive PGTA analysis, what we call our PGTai 2.0 Plus, and really with a focus on the origin of aneuploidy. And we really believe that this test is one that will help reassure, empower, and safeguard both your patients and, of course, your clinical staff. So a bit information of our background, we can trace our legacy back to the birth of pre-implantation genetic testing. Back in 1992, Dr. Mark Hughes was involved in one of the first PGTM or then PGD cases for a CF carrier where an unaffected baby was born. Similarly, in PGTA or PGS, Dr. Santi Moutne was one of the first to present the use of FISH to identify abnormalities in chromosomes 13, 18, 21, X and Y. Since then, our experts have been and continue to be involved in new technologies and new techniques. As NGS was adopted in PGT towards the end of 2012, there has been very little innovation in the space in terms of technology or the way PGT is done until probably about sometime 2018 when we launched our PGTai platform. And just really the reason why we're able to do this or launch this is that we are considered one of the leaders in the reproductive genetic space and innovators, and with many years of experience and expertise, and our platform is one of the ways in which we continue to forge this path of innovation. And I would like to give you a brief overview of our platform, how it was developed, and perhaps maybe why we decided to move in this direction. So information about our PGTai. PGTai really is our analysis tool in which we analyze genomic data. So we are amplifying and sequencing samples on a next generation sequencing platform. And then we, instead of utilizing an older methodology, which most of it is done today by others, we have developed our own analytical tool to analyze genomic data. And one of the main reasons why we did this is because we wanted to do away with some of the limitation that exists in PGTA today. We have the experience and expertise as mentioned earlier, and so we're able to leverage some of our big data, the massive amounts of information that we've accumulated and over the years of doing PGT testing. And also we wanted to do away with depending on subjective interpretation. We wanted to depend on mathematics and statistics and do away with subjectivity altogether. And of course, a huge impact on this is automating our overall calling. So we are a global organization with laboratories in the Americas, in Europe, and Asia. We wanted to ensure that regardless where a sample is going to be analyzed at, that sample is scrutinized in the very exact same way. And also, we've taken a different approach than what's been done in the past, where analysis and algorithms are developed utilizing cell line samples, which can be easy to work with, but don't necessarily always represent the true biological nature of the embryo. So instead of going with cell line samples, we decided to utilize or developed a baseline of known outcomes. So we used over 1,000 known euploid embryos to develop what a euploid embryo should look like. And we taught our artificial intelligence platform through machine learning to be able to determine what a true euploid looks like. And these known euploids had outcomes. So they either were a sustained pregnancy or a live birth at the end of it. So we knew unequivocally that when we report a euploid, it is in fact a euploid. And then of course, we extensively validated it to ensure that it's able to reproduce the same results or expected results each time. So this analysis tool is improving the way we do PGT today. It's now built on real outcome data as opposed to cell line samples. It's one that's developed on actual live birth and clinical outcomes. It's validated extensively, but the most important things is really what it's delivering. It has improved our accuracy in PGT interpretation, but also it's eliminating subjectivity, one that's been communicated a number of times at a number of conferences that it's a big limitation in PGT today. So we no longer have this user-to-user bias, and our analysis are done strictly using our artificial intelligence platform. And of course, that helps us also avoid human errors in transcription, since we no longer do this old way of looking at NGS data where NGS data is generated through a machine and then converted through an algorithm, converted into an image, where this image then is read by technicians and then a decision is made. Often you may have multiple technicians deciding and making a decision prior to that being provided to a clinician to provide, then make a decision on a transfer ability of that particular embryo. So we no longer work in this manner, where now everything, of course, is still the data is being generated via next generation sequencing platform, although the sequencers are with larger capacity and throughput. But now all of our data is analyzed utilizing PGTai, which is automatically picked up from the machine, analyzed, and then the report is generated. Our reporting thresholds haven't really changed from what we've reported in the past in terms of what we classify euploid, and then the split level mosaicism and aneuploid. So obviously for euploids, they have the highest likelihood of pregnancy and successful IVF cycles. And these are where you have the correct amount of DNA within each chromosome. And then the low level mosaic is what we classify embryos that contain over 20% aneuploidy all the way up to 40%. And then high level is above 40% all the way up to 80%. And then an aneuploid is a complete loss or gain of a chromosome. So the conversation really, and the main point about our conversation today is about the Plus platform. So what are we offering in this Plus? Since 2.0 really is our standard way in which we do PGTA today. If anyone is ordering PGTA through us, they will be getting all of the benefits that we talked about and all the benefits that we continue to talk about. But I would like to also highlight on what's included firstly on our standard test. So this is one where we're generating now massive amounts of data through our larger sequencers with greater capacity. We're also doing something called paired end sequencing, where a strand of DNA is being read from both ends to ensure that it has a greater availability of data and greater alignment to the human genome. And of course, it's helping us basically perform this more nuanced analysis and being able to determine and see more things. We also now utilize global SNP coverage, and this is offered on our standard platform. So this is then giving us two methods in which we identify aneuploidy, our CNV and then our SNP coverage. The difference between the two is in that Plus, you are we are obtaining parental samples, and parental samples are obtained via cheek brush or buccal swab test. And this is then giving us additional information on the parents. It's helping us determine the origin of aneuploidy, but also giving us the ability to see all forms of triploidy. So in most cases, and in tests that typically PGTA, one of the limitations is that you are unable to detect female triploidy, and those embryos tend to be reported as normal euploid embryos, in which case then they will get transferred and of course lead to miscarriage. So with the advent of parental samples and the ability to look into the parental samples and then compare that to the embryo sample, we have the ability to determine and identify female triploid embryos or comprehensive triploidy detection. Another neat thing that we are able to do with the Plus test is that we are able to determine PN checking. So that visual representation of PN that's typically done at an embryology practice, now we have the ability to do a genetic PN check that automatically is provided to all samples that are done on the Plus platform. So our Plus, really our PGTai 2.0 Plus, the PGTai for us has given us this incredible amount of accuracy, one that we feel very confident and comfortable about, and one that we really like to speak about. And of course, the second generation of PGTai is giving us two independent ways in identifying aneuploidy, where we are looking at copy number variation, and then now we're also looking at the SNP analysis. And then the Plus offers these additional benefits, like the comprehensive detection of triploidy, where we're hoping to reduce or avoid some of the miscarriages that are due to undetected forms of triploidy. Also, the parent of origin of aneuploidy. So with this analysis or determination, we're hoping to give information to clinics and patients and clinicians on identifying which path a patient may want to go in terms of gamete donors decisions. And then of course, the last one is genetic PN checking, in hopes that perhaps embryologists may choose to deprioritize fertilization checks, because we will automatically be providing this to you. And just moving forward on some of this reassurance and empowerment and safeguarding, we really feel that in terms of reassurance, with the detection of a comprehensive triploidy, we have the ability to really minimize the miscarriages. We already do a whole lot just by getting PGTA. Patients already have a significant reduction in miscarriage rates. But we know that triploidy impacts all IVF embryos, and about 10 to 15% of first trimester miscarriages are due to polyploidy, and those are confirmed cases where a POC was done, and roughly around 1 to 3% of IVF embryos that result in molar pregnancies are due to a triploid embryo. So really, by being able to detect some of these undetected or previously undetected forms of aneuploidy, we are hoping to reduce some of these miscarriages. And what we've already seen this play out in one of the clinics in US that presented data at ASRM at the virtual Congress in 2020, where they showed that with the PGTai 2.0, they were able to see an increase in their ongoing pregnancy and live birth rates, but also a significant decrease in their loss rates. Both of these observations were significant. They also saw additional findings, like the new platform had provided them greater opportunity for embryo transfers, which means they had more euploid embryos and more patients with at least one euploid embryo. Going on the empowering of your patients, we understand obviously that parent of origin is something that doesn't often get tested, and patients tend to make decisions just based on conversations with clinicians, and we know that in most cases aneuploidy is derived from the egg, and therefore often a decision is made to proceed with an egg donor. However, about 10% of whole chromosome aneuploidy is of paternal in origin, and over 50% of segmental aneuploidy is also paternal in origin. So it's really important to have all of the information before a decision is made, and potentially delaying time to pregnancy and delaying time to having that baby. So although these decisions we understand are difficult to make, having additional information so you're making the most appropriate decision for your patient is definitely the way to go. And with the PGTai 2.0 Plus, this gives that opportunity to patients and yourself, of course. And then the genetic PN checking. Obviously, we know that this is done, and it's done on all IVF clinics, but sometimes this could be a challenge to identify correctly, as PN may appear at slightly different times, or it may be faint, or it may have already fainted, or it may be a micro PN and may not be apparent, or vertically stacked, which makes it even more difficult to detect. So with the PGTai 2.0 Plus, you are given the opportunity to get a genetic PN check, basically confirm that the embryo was haploid or diploid or triploid. And there is certainly data that's mounting up that suggests that virtual PN checking or visual PN checking may not be the most robust way in going forward, where a study out in China showed that 0 PN embryos and 1 PN embryos had that were grown to blasts, of course, had pretty significant ongoing pregnancy and live birth rates. One of my last slides here, really talking about and tying our genetic testing to something we perform on the fertility side, which is the Eyewitness. So with the PN checking and with the addition of aneuploidy detection, or identifying where aneuploidy is originating, and having these two independent methods of detecting and being able to have comprehensive triploidy detection, we feel that we're providing this layer of protection for you and your patients by reducing some of the miscarriages, by ensuring that an embryo is diploid or haploid, and communicating that to you. But we feel that adding on something like our Eyewitness really helps strengthen that layer of protection. So you're provided added security with RFID technology. You have patient involvements where they can have a fingerprint scanning and be able to see where their oocytes are being picked up and have greater visibility into it, tracking of embryos, and of course, analysis and reporting and providing this data. And in the continuation of data, we really want to make sure that your teams are entrusted with the most amount of data to ensure that you are able to assess trends and be able to see or be able to identify where some of the improvements could be made in terms of making your clinic more efficient. So we are providing your sort of data, but packaged in a way that you are able to see trends, where we give you your classification rates, whether it was euploid, aneuploid, the number of patients that you sent us, and also we compare that to what we see across Cooper. This in hopes gives you some insights and have the ability to benchmark where you are and where we see all of our clinics performing at. This isn't something to get an understanding of where you are versus where the rest of the clinics are. It's more of trying to see if you can observe any trends, trying to see what information we could do to help, and maybe identify areas in which we can work together in a collaborative way to improve your rates or improve the way we collaborate with you. Just sort of an overview here. Obviously, as mentioned earlier, our PGTai 2.0 platform is the standard way in which we perform PGTA today. Our PGTai 2.0 Plus platform is the one that requires parental samples through the buccal swab kits that we provide to each clinic. And this has the additional improvements, like now we have the ability to detect all forms of triploidy. This means that we have the ability to detect female triploidy, which goes mostly undetected when utilizing another platform. Also giving you the ability to discern where the abnormality originates from in hopes of empowering your clinic, your patients with the information to make the proper decision for a gamete donor, but also the information on genetic PN checking. So hopefully you got a better overview of what we're offering now with the Plus test. And I'm going to send it back to Tony for questions and answers.
Thanks very much, Lena. It's a great introduction to where we are. So first of all, I would like to thank those of you who logged on early and answered our poll. We'll come to some of those questions and some of the answers in the poll in a little while. Also, just to say, in the chat function, as you see on your Zoom, you should see a Q&A. So if there's particular questions you'd like us to come back to, please put them in and we'll try and get to them after we've been to talk to Karen and to Claire. So first of all, I'd like to come to Claire. And, you know, one of the things that's really interesting is we talk about the science, and, you know, I'm a scientist. I'm in the lab. I'm not on the front line of IVF talking to patients like you folks are. So it's really interesting for us to hear, you know, of personal experiences that you've seen with patients and how this sort of technology is impacted. And I think, Claire, we were going to discuss a case that you've had recently.
Yes, thank you very much, Tony, for the introduction. So what I thought I might do today is to take you through a case. So as we just heard, all the practicalities and all of how to do and what these techniques mean, but actually what did they mean for us on a clinical basis? So this was a very interesting case for us. We have been doing PGTai testing now for just over a year. So we're not, I wouldn't say I'm any means an expert on this or the technology or anything, but this was a very interesting case that happened to come across our path. So in an effort to keep everything anonymous for this couple, I'm just going to give you a broad overview of their age profile. So both male and female partner were between 35 and 39 years. There was no significant medical history before they attended ReproMed. They were not in the high risk category for any genetic abnormalities. However, they did attend us with a history of 5 miscarriages. So they fell into the recurrent miscarriage category. Again, they had all their miscarriage screening carried out before they attended us, and nothing was observed. So they had recurrent miscarriage blood profile carried out, everything was normal. Also, both karyotypes were normal. So the male and female karyotype, absolutely fine. So our first line of treatment was to do a cycle, a NICSI cycle with PGTai. And on that first cycle, the couple got 3 blastocysts that were suitable for biopsy on day 5. And the results showed that 2 of these embryos were aneuploid, and unfortunately 1 embryo got no result. So of the aneuploid embryos, we had a trisomy 15 and a trisomy 16, which are considered to be non-viable when present in all cells. So the couple decided to go for a second cycle, thinking, okay, maybe it was bad luck on the first cycle, let's go for another one. So we did another cycle of PGTai. On this cycle, the couple got 5 blastocysts for biopsy. However, 3 of those were aneuploid. 1 was a complex abnormal mosaic embryo, and 1 was a low-level mosaic. So slightly better news this time in that there was a low-level mosaic, but still we had this ongoing issue of a very high number of aneuploid embryos. So for this patient's age, we would expect, about 50% of embryos to be euploid, but at this point, we still had no euploid embryos. So again, I suppose this was a kind of a time to pause and consider what to do next. We had male and female couple, normal zoospermia, normal AMH, normal response to medication, no ongoing medical issues. So as a next step, I suppose it was fantastic for us that we had a next step to do. So we had the PGTai 2.0 plus in order to try and determine the source of these aneuploidies. So we had a discussion with the couple, and they were very happy to go ahead with this, both as a prospective and a retrospective analysis. So they decided to do 1 more cycle, and also at the same time to do the parent of origin testing on the previous embryos that had been tested. So we sent them with the cheek swabs, and that was a very simple process that the patient was able to do that themselves at home. There was no issue, and they sent the cheek swabs directly back to Cooper Genomics. And that was all very, very easy. So in the meantime, we prepared for the 3rd cycle. And the plan was to test all the embryos from the new cycle and also the previous 2 cycles. On the 3rd cycle of PGTA, we got 4 blastocysts for biopsy. Again, the result was a very high aneuploidy level. We had 3 embryos that were aneuploid and 1 with no result. So at this point, we had 3 cycles, a total of 12 embryos tested, 8 aneuploid, 2 mosaics, and 2 no results. So that was a 66% aneuploidy rate for this patient. Now, when we looked at the PGTai 2.0 plus results, it was really, really interesting for us. So from the first cycle, from those 2 aneuploid embryos, both of those were maternal in origin. From cycle 2, from the 3 aneuploid embryos, we had 2 that were maternal in origin, but surprisingly 1 paternal. So there was, a paternal factor there as well. In cycle 3, we had the 3 aneuploid embryos, and again, all 3 were maternal in origin. So the conclusion for us was a clear egg aneuploidy factor here. And again, I suppose this showed to us that, you know, even a patient that's not in the risk category has a normal AMH level, everything looks fine. Like, it was fantastic to get this extra layer of diagnosis for her, because after those first 2 cycles where we knew there was a lot of aneuploids, at least we could confirm the diagnosis on the 3rd cycle. And I think that is the real learning that we found from this. Like, it was just a fantastic tool to allow closure for the patient, and to, you know, give us a really good diagnosis, or that extra layer of diagnosis, that we're not just assuming, okay, well, look, it must be an aneuploid issue. We actually have proof that it is a maternal aneuploid issue. So I suppose that was our clinical experience of it. And for us, I just thought that was a really interesting case, that, you know, you can see the technology in action, and it was fantastic for us for this particular patient. So thank you very much.
Claire. Thanks, Claire. Yeah, a really interesting case, and it does, you know, it is interesting when you see people who've gone through so many cycles, you know, they're continually going with cycles with seeing aneuploidy, to actually get a rationale for it must be I'm not a genetic counselor. I'm going to ask Karen. I'm not a genetic counselor, but I'd imagine it gives them some amount of, well, like you say, closure is the best way to describe it.
It is, yeah, because I suppose for us, you know, after we had done the first cycle, we think, okay, well, we got 3 embryos, so okay, look, it was bad luck to get 2 aneuploids from that. The next cycle we'll definitely get 1 euploid. You know, you're kind of confident that you will get something, you know, based on all the statistics. She should have got 1 euploid at some point. And just when that second cycle didn't work out, I think, you know, at that point, if there was no further advancement in the technology, that would have been it, really. Like, there's not really any point in doing another cycle to get the same result, but to know that we can add an extra layer on now for the next cycle, like, that was what was really, really good for us.
Yeah. And it's, you know, it was particularly unfortunate that they had 2 no results out of 12. There was a question came through to ask how common that is. So our no result rate is it's less than 2%. So they were, you know, doubly unlucky, I think you could say. However, there is indications that, you know, egg quality, embryo quality can lead to no results as well. So they were just, I think, every circumstance conspired against them, really.
Exactly.
Super unfortunate.
Exactly, and that would be our experience as well. Our no result rate is very, very low. So for 1 patient to get to no results out of 12 is unusual as well.
Yeah, it was a particularly sad case. Yeah, very interesting. So Claire, I'm just going to move over to talk to Karen for a little while, but please, you know, this is very informal. If you'd like to jump in at any point, please do, because it's interesting to hear your opinion as well. And Karen, welcome, and it's great to see you. I had a few questions that sort of occurred to me that we were discussing before this, and one of them was sort of generally, I mean, you're there on the front line talking to patients, and how much do patients actually realize, do you think, before they come to you? And Claire, if you've got thoughts on this as well, how much do they actually realize the effect of aneuploidy in infertility, particularly with maternal age? Are they realistic, do you think?
Hi, thank you, Tony, for the invitation to speak. I think it's changed over the last 10, 15 years, and with the uptake of PGTai, or formerly PGS. But to be honest, I think most people are just struggling with the idea that they really need IVF in order to achieve a pregnancy, and they may understand, you know, most people know that as women's age increases, then the risk of Down syndrome goes up, but they don't really understand how much that relates to the developing embryos. And I think it's not just the patients, but I think that don't understand that they do understand when they're told or they are informed. But I think it's also some of the doctors and the clinicians who are maybe not discussing that at the first instance. Yeah, so there's a little bit of education, in other words, that's required.
And also, you know, I think Claire's example was a perfect example of our genetic understanding of the paternal role of aneuploidy there. You had one paternal aneuploidy amongst 8 embryos that came out. I would say that that's kind of where we expect. I mean, it also, you know, not just aneuploidy, but, you know, do couples realize that it is mainly maternal when they come to you, and that there's, so far we can only describe a very small role of paternal aneuploidy?
Yeah, I think we assume it's maternal. We assume it's down to advancing maternal age, but we get these subset of patients where we really struggle. And Claire's example is perfect. So we see this in IVF patients where we're expecting a 50% aneuploidy rate if we discussed it and we're looking for that PGTai results. And then all of a sudden we see this complex aneuploidy and it's 100% aneuploid. And they're the cases that we are really, really struggling with. So to have an additional tool in the tool set, if you like, is really helpful. And I think Claire's case kind of describes that really well.
Yeah, I just want to go back, Claire, because we did get a question come through on the Q&A, and please, if you have questions, please put them through on the Q&A. And it was a question about rebiopsy, and it was a question whether you attempted to rebiopsy those no result embryos.
At the moment, we haven't done that yet. This has all happened relatively recently. The PGTai Plus cycle was just in December of last year. So the patient is still processing those results. So they haven't come back to us yet with a plan. I think their plan is maybe to do one more cycle in the hope of getting that euploid embryo. But yes, I think it is a plan in the future if we do another cycle to maybe rebiopsy those embryos. But as I said, they're still considering their options now because, you know, I guess they came to us looking for answers and maybe we didn't give them the answer they wanted. You know, we gave them a definitive diagnosis, but, you know, one that is very hard to accept, really.
Yeah, indeed. And actually, once we've gone through this, I'll go back to Lena and David, because they can tell you a little bit about our rebiopsy success rates. I know that we have a webinar coming up in the future on rebiopsy, so I don't want to steal the thunder of that, but I'm sure David and Lena can give you a quick sort of summation of where we are. And just generally, I mean, well, I know we're talking about the origin of aneuploidy. Do you tend to offer PGTai if there's a clear indication of male factor, Karen, Claire?
Sometimes, actually, it's not the default position, and I think it's assumed if you have I think there's some evidence now for testicular sperm that the sperm will produce a level of aneuploidy, but we haven't been able to really track it. We haven't had a tool to do this. So I think this is where the COOT testing or the PGTai Plus will be really, really helpful for some patients to move forward.
Absolutely. So at the start of the webinar today, we posed a question, and we tried to carefully sort of script it so that we could get a reasonable answer in terms of, we asked the situations if you had, clearly you can't tell, you know, if you have an aberrant origin of aneuploidy if you only have 1 or 2 embryos because it's not really robust, but if you had 5 or more embryos reported as aneuploid in a cycle, what would you do? And there was a multi-choice, whether there was gamete donation, whether you consider further cycles, the test for the origin of aneuploidy, or genetic counselling, or all of the above. Karen, you will be probably heartwarmed to know that genetic counselling was the top answer here. And, you know, in this circumstance, what do you think, you know, you really need genetic counselling for these couples?
Yes, I think so. I mean, I think as Claire's just illustrated, you know, you haven't immediately defaulted to rebiopsying 2 embryos with no result. the patients need some time to digest that information. And that's where genetic counselling can come in, really, really helpful, just to guide next steps and then to review and think. Yeah, it's great. I'm pleased to see the results of the poll.
Yeah, I completely agree there on that. This particular couple had genetic counselling after the second PGT cycle, and that took a while to process the information. You know, as I said, it does take a while to process that information and to decide to either rebiopsy the no result or to move on with another cycle. So there is, you know, a big turning point there and a lot to discuss. So the genetic counselling was fantastic for us, I have to say.
Yeah.
Yeah.
There's another case that this comes up quite a bit actually in our big meetings, where we have euploid embryos which we transfer. You know, everything is fine apart for going forward for a frozen embryo transfer, and they fail. And we come back with clinicians, we discuss, you know, why are these euploid embryos failing? Now, it may be possible that they're triploid. Who knows? I mean, this is just another. But we could actually look deeper into that if we wanted to understand, is there a reason for this euploid failure? Apart from, you know, it may not be embryo factor, it may be something else, it may be an endometrial issue or a blood issue, but we do have something that would help.
Yeah, and you know, it's a really interesting comment from Jen Sloan, our genetic counsellor here, and it's to say that, you know, we can give information on a global data set, but every patient's circumstances are unique to them, and I think that's when the origin of aneuploidy brings it to become a personal result rather than a global data set. This is where you are on the graph, where you are on the spreadsheet. One of the things that I was going to ask you about, Karen, as well is, and we discussed a paper before this presentation, and it really impacted the importance of aneuploidy and how it's perceived. And that was the non-selection trial from Ashley Teague. And this was a trial where they did IVF and they biopsied embryos, and then they implanted those embryos without the knowledge of whether they were euploid or aneuploid or mosaic. And then they looked at the outcomes. So it was blinded to the genetic results in the transfer. And they did, I think, just on 100 transfers where the embryo subsequently turned out to be aneuploid. And they had no live birth trisomies, which was a fingers crossed moment, I think, for their trial. But every one of those embryos didn't implant and result in a healthy live birth. And do you think that sometimes we understate the importance of aneuploidy in these sort of circumstances? Or, I mean, you must really have to reinforce it to patients that, you know, we were talking about it before about, you know, situations where people even consider, because they're so desperate, transferring aneuploid embryos.
Yeah, I think it's a really interesting paper actually, because it's about the predictive power of an aneuploid embryo. And there's absolutely that everybody agrees that that embryos that we develop in IVF labs there's a level of aneuploidy in there. The debate is really about whether transferring euploids increases pregnancy rates, which is a different issue. This has really changed. I mean, when I read that paper, I was just really intrigued that, you know, this is proof positive that transferring aneuploid embryos, thankfully, did not result in a trisomy live birth outcome, but also didn't result in any outcome. So it's a really quite nice. It's a nice piece of evidence for exactly screening embryos, I would say.
Yeah, absolutely. I'll come back to Claire and Karen in a moment, but we have some questions that I was going to ask for David and Lena to comment on. And the first one goes to David, and it was a question about when we are doing PGTai, do we need to have ICSI, or can we do IVF as well?
Yeah, we get asked that quite a lot, and it's standard IVF is fine. We don't need ICSI at all. The amplification technology that we run at Cooper doesn't amplify sperm DNA. We've shown this conclusively. So really, yeah, you don't need to worry. IVF is absolutely fine. It doesn't matter whether it's PGTai AI or the plus version, it's fine with IVF.
And the second question is to Lena, and it's about rebiopsy. What are our success rates in rebiopsy? And I would also pass it back to Karen and Claire, and whether you would recommend rebiopsy in most situations. Lena.
Yeah, Tony, that's actually another common question we often get about rebiopsying no results. So as you mentioned earlier, our no result rate is really low. It's below, on average, 2%. And we do get clinics who often will rebiopsy a no result embryo, which 50% of those biopsied or rebiopsied yield a euploid result. So just because an embryo resulted or didn't result into an answer doesn't mean that it is necessarily aneuploid. So what we see is that the vast majority of embryos that are rebiopsied are actually tend to be euploid, and greater than 98% of those rebiopsied actually get a result. I think there's some data that's been published by others that's similarly to what we see internally at Cooper.
Thanks, Lena. And Claire and Karen, do you normally recommend rebiopsy in most circumstances?
Yes, we do recommend it. Again, our numbers are quite low. I suppose our numbers that need rebiopsy are quite low. And then again, the numbers of patients that choose that are quite low. But we have done it. We have done rebiopsy and we have got results. Again, our numbers are not high enough to draw any conclusions, but off the top of my head, I don't remember any case where we didn't get a result from a rebiopsy. So it tallies with your statistics.
You have an unfortunate problem unable to answer this because you're too good at biopsy, which is a great situation to be in. Karen.
Yeah, we definitely we check with the embryologists if the embryo will survive a thaw and a rebiopsy. And if the answer is yes, then we rebiopsy. And we have got euploid results from those rebiopsies and live birth results, so live birth outcomes. So it's the care group that I work for as an advisor, we have that data, and I believe we are hoping to publish it. So we've got some nice data there with the rebiopsy.
Fantastic. And we did actually have a question, which is an intriguing one, and I'm not sure whether we have an answer for it. So it's a bit of a tricky question. And if you have any questions, please, we still have time to put them in the question and answer in the chat function. It says, have any of the labs reported a link between older female patients and a higher risk of inconclusive results? I don't think I know of anything specific on that. Anybody else want to try answer that one? There's lots of shaking of heads.
Yeah, I don't. No. I couldn't answer that because I wouldn't have enough data on that to make any conclusions. No.
No, I go to someone like Cooper for the answer for that.
Sure.
Yes, so would I.
Yeah, and I don't think that we have an answer for that either. As when we went back to our question about the 5 embryos reported as aneuploid and what would you do, one of the interesting things I thought, and it obviously depends on personal circumstances, whether it's the first cycle or whether they've done 5 cycles or where they are, you know, emotionally, financially, age-wise. But we did ask, you know, when would you discuss gamete donation? And actually, that was the thing that came back as the least frequent things for people to do. I presume, Claire, Karen, it's just because that's a really difficult conversation.
Yeah, I mean, some people, it absolutely depends where they are on their journey. And this may be if they've struggled and they've had multiple failed cycles and multiple cycles where there are aneuploid results, then this may be something that they're more open to discussion. But if we don't have that data, it really depends on the couple. Just like Jen Sloan said a minute ago, every case is different. But we do introduce gamete donation at some point, and having this information might help people get there a little bit quicker.
Yeah, I think it really depends on the couple. There are some situations, I think, where it's easier to introduce gamete donation. And I suppose from my point of view, it's easier to introduce it maybe when they've never had a pregnancy, or, you know, don't get to blastocyst. You know, they might try and do a PGT cycle, but they don't get any blastocysts. And in those cases, it's easier, I think. But for somebody who's got, you know, essentially unexplained infertility, it's very, very hard to introduce the topic of gamete donation to a point. Like, I think, again, in this couple of scenario, it has been discussed, because really, I mean, there's not much more we can do now, you know, except to repeat the process multiple times. So yeah, it's a difficult one.
Absolutely. So one of the things that we've discussed internally at Cooper about this before comes to a specific circumstance, which is 5% of aneuploidy, and they are what we call the segmental aneuploidies. They are where you get a part of a chromosome gained or lost, not the whole chromosome. And there was a very interesting couple of papers that have come out recently that have used the technology that we actually use for PGTM, carrier mapping, to identify the origin of aneuploidies in those segmental aneuploidies. And they seem to be predominantly paternal, which is the first time. And I just want to ask David really how the difference between what we're doing here with PGTi 2.0 plus and carrier mapping, whether we can look for the same segmentals in this technology, or even, you know, more segmentals.
So yeah, that's a great question, actually. So the great thing with PGTi 2 plus is it is fundamentally a copy number assay. It was built from the ground up to be absolutely a copy number assay with resolution, which will go down to 5 megabases for these segmental changes. So we probably see more segmental changes in PGTA than we do in PGTM due to the nature and the accuracy of the platform. But it does mean that absolutely with PGTi 2 plus, we can see these 5 megabase changes or greater, see whether it's male or female derived, and start looking at the stats of that. And that's an ongoing project in Cooper to keep that data going. But actually, yeah, we can see whether it's male or female, even for these small segment changes. And it's probably, well, as I say, the assay was designed to do copy number from the ground up, whereas carrier mapping is forced to do some of these changes.
And just one last question for David and Lena. Are there limitations to what PGTi 2.0 origin of aneuploidy can do, specifically with mosaicism?
Yes, is the short answer. So this is meiotic changes only. So we can only do complete copy number changes. So mitotic error, which is what we believe, and the evidence points towards mosaic changes being mitotic, so a post-fertilization error and then a cell division. There is a male and female component, a mum and dad component in a lot of those cells that the parent of origin will still detect the presence of that parental sample. Where you have a meiotic error, where it's a full dosage of either twice as much or an absence, then this is where we can see the parent of origin testing. And that's really what you're looking for, because it's oocyte errors or sperm errors which we're looking for in parent of origin. I don't know if Lainey would like to add anything additional.
I think you covered it, David. Thanks.
Cool. And I think it's quite a difficult one technically to explain. But I'm sure, Karen, you might have to come across this as a potential issue for origin aneuploidy testing.
What, the segmentals?
Yeah.
Yeah, I mean, I've come across it certainly with the carrier mapping, just UCM cases. For, I think we with the PGTA, we're seeing the segmental, we're not seeing segmental meiotics being reported at the moment, but that's because we have requested not to see that. And I was intrigued to see the paper in the talk in Lena's section that there was a 70% segmentals that were paternally derived. So this is You know, that's really something I've learned today, and I'm going to kind of digest that and think about what we can do with this peak testing. Really interesting.
Yeah, it's interesting. We don't know, because it's still early information. We don't know whether that's associated with any form of paternal age, whether, you know, advanced paternal age is great for that or not, because we've not looked. And we don't really understand yet whether it's associated with male factor. That's ongoing research, as I understand it. But it's certainly, it's quite dramatic when you go from whole chromosomes, you know, 80–90% maternal, to parts of chromosomes 60 to 70% paternal. It's quite a dramatic change, and it actually reflects what you find in prenatal diagnosis, where those segmental changes that make it onto, you know, long-term into pregnancy or affected live births are paternal, mainly in origin. So it's nice that it fits with the other biology. So it's kind of fascinating. So, sorry, Karen.
No.
So yeah, we were just getting towards the end. We had our poll, and I think that Danielle is going to put the poll up at the end as well, just to see if we've changed anybody's opinions here. So I think if there's anybody else wants to vote, well, please go ahead. And we had a last couple of questions, see if we can fit any of them in. Have any labs reported aneuploidy in donor cycles, and how would you foresee this being dealt in terms of donor banks? So I guess the question is, if you see aneuploidy in a donor cycle, can you do origin of aneuploidy testing? Lena or David, do you want to take that one?
I can take it. Yeah, so we can do it. However, we would need a buccal sample from the donor as well. We are able to accept anonymized information from the donor and make sure that that remains anonymized, but we would need that buccal sample from that donor.
Okay, and I think we have time for one last question for David. Can we offer testing on non-viable whole embryos if they aren't getting to blastocyst? I think that's, as a general, you know, more information for the couples question.
If they are tubed properly, then yes. And when I say that is, we would need them denuded and put in the tube as a whole embryo. You don't have to send a biopsy, but yes, we can process whole embryos samples for the origin.
Well, I mean, I think that's a really interesting point to end, as ever. And I do warn the attendees that you think that an hour is going to drag on, but you get to the end and you're running out of time, and you've had a great conversation. So I would just really like to thank Claire and Karen for coming and giving their experience in this field. As ever, it's great to hear what actually is happening on the front lines of the genetic testing in IVF. Lena and David, thank you for your contribution.